Hello, doctors. Nice to see you again. Let me introduce the topic of the lecture, acute rhinosinusitis. As you can hear, it consists of two parts, rhinitis and sinusitis. Rhinitis is irritation and inflammation of the mucus, which is covering cavity of the nose. And sinusitis is irritation and inflammation of the mucus membrane inside the paranasal sinuses. But to be truthful, the symptoms from both of them are really similar, except that there is no clear margin between the cavity of the nose and cavity of the sinus. And the mucus which is covering is quite the same. That's why from early 90s we are using such word like rhinosinusitis. It recognized that rhinitis and sinusitis, they coexist, and that physiological and pathophysiological is difficult to make a distinction between the nose and sinuses. We have today a nice protocol. It's European position paper of rhinosinusitis nasal polyposis, shortly it's called EPOS. For the first time it was published in 2005, then published 2007, and again 2020. That was the biggest type of that protocol. Now we have a new one, 2020. It's mostly 90% similar to 2012. Just there is some improvement or some mistakes or some other investigation. And today we're using that protocol, 2020. Sorry. Well, acute rhinosinusitis definition is sudden onset of two or more symptoms, one of which should be either nasal blockage, or another way we can call it obstruction, congestion, or nasal discharge, anterior or posterior. In adults, it should be facial pain also, or reduction or loss of smell. And in kids, it's different. One of the symptoms is cough. Very important, the duration of the problem is shorter than 12 weeks. Also, we have something like that recurrent acute otitis media. The picture on the top, you can see there's an episode, indirect line episode of acute rhinosinusitis. It will start and will be finished. Then, healthy person. The last one, it's again acute rhinosinusitis. Stopped, healthy person. In a few weeks, you have again new episode. And again, new episode. Now, recurrent acute rhinosinusitis is defined as more than 4 episodes per year with symptoms-free interval. And also important that such episode have clear symptoms of acute rhinosinusitis. Epidemiological. Well, the problem is really common. That is primarily managed in primary care. It affects nearly 15% of our population. During the flu epidemic, it happens much more often. It appears nearly 50% of the patients. Adults suffer from 2 to 5 episodes per year, and kids from 7 till 10, and it's a healthy persons. In nearly 2% cases, it will be bacterial. Again, more duration. If it's shorter than 12 weeks, it's acute. If longer than 12 weeks, it's already chronic. Also, we have from that protocol something very nice. We can put the severity of the disease, but it's very interesting. It should be done by a patient. The patient will have a question, how troublesome are your symptoms of rhinosinusitis? And the patient have point in the scale, like here. For example, from the left side, it's completely easy. There is no troublesome. The patient will feel himself perfect. Or from the right side, the last point, the patient feels himself awful, very difficult, worst thinkable, troublesome. And the patient have to choose. And to do that, we give him the severity of the problem. Classification. The first in that classification is common cold or acute viral rhinosinusitis. Duration of the symptoms should be less than 10 days. Well, here we got the picture with the main symptoms of acute rhinosinusitis, and you can see that most of them finished on the day number 10, or they're sharply decreased due to that period. That is acute viral rhinosinusitis or common cold. Second one is called acute post-viral sinusitis. Uh, it have the two types. Now look at the picture. First one you got in blue line, it's a common cold. On the fifth day, symptoms are decreased and they should be stopped in nearly 10 days. But when, for example, after 5 days, the symptoms are again increased, or the persistence of the symptom after 10 days, we are calling that acute post-viral rhinosinusitis. But it's very important, it should be shorter than 12 weeks. And the last one, acute bacterial rhinosinusitis. It will take nearly 2% of all cases. Well, when we can suggest that the patient have acute bacterial rhinosinusitis, should be present at least three symptoms, like discolored discharge with unilateral predominance, severe local pain, again with unilateral predominance, high fever, elevated biomarkers like ECR or CRP, and double sickening. Well, when you look at the picture, you can find out that is complete all patients with acute rhinosinusitis, and the biggest part will take patients with acute viral or common cold. Nearly 18% it's acute post-viral rhinosinusitis, and nearly 2% that will be the patient with acute bacterial rhinosinusitis. Well, in microbiology, primary it will be always viral, and secondary can be bacterial, but again, I'll mention it already, it's nearly 2% of the patients. From the viruses, they are rhinovirus, coronavirus, influenza, parainfluenza, respiratory syncytial viruses, adenoviruses, and so on. The most often, nearly percent of all cases, it will be rhinovirus and coronavirus. Well, viral infection will damage the defense system of the nasal cavity, which increase the risk of the secondary bacterial superinfection. From bacteria, they are my best friends. They are Staphylococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus pyogenes. The most often, again, it will be pneumococcus, Staphylococcus pneumonia, and Haemophilus influenza. Well, viral infection is the main, but not the only precondition for development of bacterial sinusitis. Also can be some superinfection, like dental infection, can be inflammation, for example, allergic rhinitis, can be some anatomical problems, for example, nasal septum deviation, hypertrophy of the turbinates, polyposis, cleft palate, and so on. Can be systemic problems like cystic fibrosis, like ciliary dyskinesia, immunodeficiency like AIDS or hepatitis C, smoking, and so on. Well, I think that you know that we got 8 sinuses, they are period, 4 from one side and 4 from another side. They are frontal sinuses on the top, left and right. They are maxillary sinus, ethmoid, and sphenoid. Well, they are placed on the face part of the head and opened all together to the nasal cavity in middle or superior meatus. That origin of the opening, middle and superior meatus, limited from one side by medial wall of the orbit, medial wall of the maxillary sinus, from another side by medial and superior turbinate, is called osteomeatal complex. This is a special viscous circle why the sinus affection appear. You have to understand it, because if you want to succeed in treatment, you have to destroy the circle. Now, the first moment important is blockage of the anastomosis, blockage of the osteomeatal complex. That will lead to reduced air pressure in sinuses and creates a negative pressure inside. Then they will affect rebuilding of the mucosa. Ciliary epithelium, amount of the ciliary epithelium will be decreased, but will be increased amount of the glands, goblet cells, which will produce transudate to be accumulated, activation of the pathogenic microflora, which leads to the mucosal inflammation, edema, and also that leads to the blockage of the nasal stomatis, and so on. It's a pathological vicious circle. Clinical examination can be done by general physician like family doctor, therapist, pediatric, or by ENT doctor. It depends from you, it depends from the law in your country. Which doctor will take care about the patient? Well, the first step, and as for me, the most important step, is patient history. I'm always giving advice to my residents or to my students, don't be lazy, talk to your patient. Talking to the patient is the most important. Sometimes it's the longest examination. During that examination, you can find out what is going on with the patient. Just to be sure, you're doing some extra examinations or tests. Also, from that examination, you can find out the duration of the problem. You can find out how prominent, how severe symptoms. Is it a common cold and it's finished on the 10 days, or the symptoms were increased, or they are persistent after 10 days? Also, during that examination, you can find out are there some prediction factors for development of acute rhinosinusitis. Well, again and again, don't be lazy, talk to your patients. Symptoms. The first symptom is dry nose, discharge from the nose. It can be muco or it can be mucopurulent discharge. Depends if it's viral or it's bacterial. Congestion of the nose. You have edema, and the cavity of the nose will be limited by edema of the mucus. Post-nasal drip. Because you have inflammation of the nasal cavity, they will produce extra production of the pathological discharge, and that discharge will fall down to the corners, to the nasopharynx. Like look on that picture, you can see the overlap, you can see the tonsil, one another one, that is the tongue, and in the posterior mucus from the nasopharynx, there is the pathological discharge from the nasopharynx. And that pathological discharge is falling directly to the larynx. And one of the symptoms, it's very special, especially in kids, is cough. Due to edema, as I previously already mentioned, due to edema of the mucus, all parts of the nose are blocked, and also is blocked superior part of the nasal cavity, where are placed olfactory cells. And due to that, you got reduced sense of smell, and secondly, reduced sense of taste. When the food is not tasty, you are sick, for sure, your feeling of appetite will be decreased. One of the symptoms is fever, stiffness, headache. Headache can be due to intoxication, viral bacteria, or can be due to affection of the sinuses, and depression. Nosebleeds happens often. It's one of the symptoms, especially of the viral type. Well, viruses they will destroy the epithelium of the nasal cavity, and especially on the nasal septum, where that epithelial part is very thin. Vessels are placed superficially. That's why they easily can be damaged. Well, what we are doing when we have acute rhinosinusitis, we want to blow up our nose, we increase the pressure. One of the explanation why we have nose bleeding, or we are using our finger to clean the nose. It's also lead to damage of the mucus. And remember, viral infection is very toxic for the vessels. It's another explanation why you have nose bleeding. Well, clinical examination will start from anterior rhinoscopy. It can be done by an ENT doctor, but in some countries it should be done also by a family doctor. We will use a special lighter, a special instrument, nose instrument to be wider in the nostrils, or otoscope. But the information from the test is really limited because we can see very nicely what is going on inside of the nostrils, and we can see anterior part of the inferior turbinate. But what is going behind, it's very difficult to find out. For example, look at the picture. Well, we can see clearly anterior turbinates, and one from another side with some pathological discharge. But what is going on inside is very difficult to find out. Oh, like here, it's more typical turbinate. Its anterior part was completely filled by some pathological discharge. It's blocked. but what is on behind is very difficult to understand. Temperature. Well, if you got temperature, it can indicate about more severe problem, and a fever of more than 38 degrees is significantly associated with the presence of bacterial infection. Inspection and palpation of the sinuses. We can do percussion. Percussion can be possible only in the case of the frontal sinus. We'll make a percussion movement on the frontal part of the face. Or palpation, we can palpate maxillary sinus and we can palpate frontal sinus. The rest sinuses, they are not possible to make a percussion or palpation because they are placed deeper in our head. Well, what about the pain? It's very interesting. The pain most often is localized in the origin where the sinus is present, but sometimes it can be irradiated to the neighbor places. For example, frontal sinus, you got the point. The main symptoms will be placed here in the frontal part, but it can irradiate to the inner corner of the eyeball or to the ozygomaticus. Also can irradiate to the temporal part. Maxillary sinus, mostly is, yes, origin of the pain is on the cheek, but it can be irradiated to the temporal part. Ethmoids, it's inner corner of the eyeball, its eyeball, and superior part of the temporal part. The most interesting is sphenoid. The patient couldn't clear, indicates the origin of the pain. He is telling that he got pain inside of the head. Nasal endoscopy. Well, it's also visualization of the nose, but it's much more complicated, and it can be done only by a highly educated specialist, by an ENT doctor, except that it's quite expensive. That's why it's not possible, it's very difficult to be done by a family doctor. Why it's better? Because we can insert the endoscope much more deeper in our locality, behind the anterior part of the inferior turbinate. We can see what is going inside. For example, on that picture, on that photo, you can see it's already middle turbinate. Here you got the middle pathway, and from that place, you got pathological outflow, pathological discharge, and bulging over the mucus. Or like here, again, middle turbinate. You got somewhere there is natural opening of the maxillary sinus, and I got directly from the maxillary pathological discharge. That picture showing to us already nasopharynx. That's choanus, and behind them we got nasopharynx. And we got if you have pathological process, pathological discharge like here, it indicates us that the problem is placed in the sphenoid or posterior ethmoids. It's an endoscopical picture. I will show you a short movie. Well, we start from the right side. I will stop it here. Well, there is the picture, which we can see by simple anterior rhinoscopy. Well, we are producing deeper. Look here what we have. It's middle turbinate. Over here, partially you can see inferior turbinate, and between them we have middle pathway, middle nasal pathway. And here you can see pathological discharge directly from the maxillary sinus. Now, continue. Look at the pathological discharge, it's pulsating. Well, once more. Well, it's right side. Now we're going to the left side. To check what is going inside. Look, we are coming deeper, and it's very interesting. You stop. Sorry. Over here. Look, you can see the middle turbinate. Over here it's inferior turbinate. It's middle pathway, and over here it's black spot. It's a natural opening to the left maxillary sinus. It's opened. There is no pathological discharge, no hyperemia, no edema like it was from the opposite side, and it's telling to us that that sinus is not affected. It's completely healthy. Now, next examination is bacteriology. To be truthful, we are not doing that routinely to every patient. In the case of acute rhinosinusitis, we are doing that only when we are doing some scientific work, or if you have recurrent rhinosinusitis. Imaging can be sinus X-ray, can be transillumination, can be CT scanning, or can be ultrasound. The first one and the most popular is X-ray. X-ray is very cheap. It's present in every hospital. Can be done very fast. There is low grade radiation. That's why it's very popular and it's very widely spread between the patients and between the doctors, especially family doctors. But you have to remember that it's limited usefulness because of big amount of mistakes. Look at the picture, you can clearly see the orbit, one and another. You can see the foramen piriformis, its entrance to the nose. You can see maxilla, frontal sinuses, and that's all. You couldn't see the ethmoids. They are localized somewhere here. You just can find out some secondary changes, but not clear changes on the opposite side. And completely couldn't see the sphenoids. That is also the reason why it has limited usefulness, because it's limited only by maxillary sinus and frontal sinus. Now look at the picture. Here you can see the complete darkness of that sinus, and also you can see the level of the liquid inside the frontal sinus. Yes, we know it's maxillary and frontal sinusitis. In that picture, left sinus is darker than right sinus. You can suspect sinusitis. In that picture, it's also you can see the level of the liquid in both sinuses, but what is going on with frontal sinus? We couldn't see it. Is it darker? The problem is that it is just absent. Here you can see little sinus over here and little sinus over here. Well, typical mistakes. Look at the picture. That part of the picture is too shiny and that part is too dark. For that reason, it's very difficult to find out what is going on with frontal sinus. Except the quality, we can see the level, we can see the borders of the sinus, but to understand there is some cloudy, some darkness, not really clear. Another mistake, looks like a level of the liquid inside of the maxillary sinus, but it's not a level. It's a mistake of the person, of the doctor who was doing that photo. It's a pyramid of the temporal bone. We have wrong position of the patient during X-ray test. Transillumination diaphragmoscopy. Well, it was advocated in 1970. You have to take a lighter. You can take a simple lighter and touch it to the origin of maxillary frontal sinus and it will shine. You can do it, but it's very difficult to understand what is going inside of the sinus. Do we have edema or liquid? We can see clearly the level of the sinus, but what is going inside is it's very difficult to understand. Except that it's limited by frontal and maxillary sinus. Also, for conducting such test, you need completely dark room, completely 100% dark room. Thermography also have limited usefulness. Theoretically, they are telling that origin which are red in color is telling that we have inflammation inside. But it's very difficult to find out the level of that inflammation. Is it limited by some sinus or, for example, by a cheek? CT scanning, computer tomography scanning. As for me, it's the best type of examination. Examination of the paranasal sinuses. Have a very nice result. We can see clearly the bony structures. We can see clearly what is going inside. However, we shouldn't use it as a fast test for the patient because it's quite expensive. It have also big level of radiation. That's why I'm not using that in routine cases. We are using that, for example, in the case when there is unilateral signs or difficult condition of the patient or failure of the previous treatment, or for example, we suspect complication. Well, we are not using that routinely in the case of acute rhinosinusitis, but we are using it quite often for the patient with chronic rhinosinusitis. Why that examination is much more better? First of all, we can see the patient in 3 dimensions. We can see every point in three dimensions and we can understand. Well, for example, like in that picture, we got maxillary sinusitis affection, ethmoid, and frontal sinus. Look here, the same in sagittal view, you can see the frontal sinus, and you can see all ethmoids from anterior to posterior. And it's very interesting. We can see sphenoid. Also, due to that examination, we can see that what is going on with neighbor structures. For example, look here, we got dental problem, dental cyst, there's dental material, and etiology of that sinus problem, it's dental disorders. Also about complication, we have some complication, it's really helpful. Like in that case, you can see there is a big cyst, it's abscess of the ethmoid. We can see that ethmoid, we also can understand that we got over here a rupture of the bone which separates the ethmoids from the orbit. We can see the position compared to the orbit and to the brain. Another examination, imagine it's ultrasound. Well, in my country, it's not really popular, but in Germany, every doctor or his working physician have ultrasound scanner, and he's doing that examination to a patient when he suspects acute rhinosinusitis. As for me, it's quite difficult to understand what is going on inside of the sinuses, but there is such test. Another test is a red blood test. Seroactive protein is a hematological biomarker. We know that it's raising when we have some bacterial infection. And its use has been advocated in respiratory tract infection as an aid to targeting bacterial infection, and so in limited unnecessary for antibiotic use. Another blood marker, is called procalcitonin. It's also, when it's growing, it indicates about the bacterial infection. However, there is not enough evidence, and we need still to investigate that biomarker. The last hematological, not the last, but next hematological biomarker is called erythrocyte sedimentation rate in plasma viscosity. That test is very popular between the patients. They are really afraid when it's growing, but it's a race. It can indicate about the severity of the problem and can indicate us about more aggressive treatment. Nasal nitric oxide, it's a metabolite which produced in upper respiratory tract, especially it is produced in the paranasal sinuses. That test is used, for example, in the case of trachea and bronch inflammation. Also can be used for understanding what is going on inside of the sinuses, but we still need further research to understand how it is important. And there are some other investigations like mucociliary function, nasal parency, neural function. We're not using that routinely for every patient. We're doing that especially in the case when we're doing some scientific work. Management of acute rhinosinusitis. Management of acute rhinosinusitis. First of all, we have to remember that it happens quite often, especially in cold time and winter time, and very often it's self-limited problem. In Ukraine, we have such a joke. We are telling if the patient has a common cold and he will take a treatment, the problem will pass in 7 days. But if he will not take a treatment, the problem will pass in 1 week. That joke explains that very often that common cold or acute viral rhinosinusitis is self-limited problem. On the other hand, many patients, they are self-managed. They didn't visit ENT doctor or family doctor. Or in some cases, they can use pharmacy and listen to prescription of the pharmacy. On the other hand, both family doctor and otolaryngologist or NT doctor can take part in managing acute rhinosinusitis. It depends from your country, it depends from your law, which doctor should be primary doctor. In Ukraine, if the patient wants to have a free consultation, first of all, should take consultation from primary doctor, and if he doesn't succeed, he will refer the patient to the otolaryngologist. But if he wants to visit an NT doctor as a primary doctor, he has to pay. Okay, we are going again to EPOS. EPOS giving to us big list of medication which can be used for treatment of acute rhinosinusitis in adults and in kids. As you can see, it's pointed in green. And also, very interesting, it's given to us level and grade of recommendation. And also, it explains which drugs should be used, which drugs are effective, or which drugs are completely not effective. We'll start from antibiotics. They are on the first place. They have the biggest level and grade of recommendation. But remember, they should be used only in the case of acute bacterial rhinosinusitis, and it will take nearly 2% of all patients. Well, there was no benefit for prescription of antibiotics for acute post-viral rhinosinusitis. There was completely no effect for cure, for duration of the problem, but there were more, happened more often adverse events. Well, there was the biggest amount of tests done for antibiotics. There was, but you could see only double-blind, randomized, placebo-controlled studies. You know that rhinosinusitis is the fifth most common diagnosis for which antibiotics are prescribed. They are helpful, you have to prescribe it, but you know that the usage of antibiotics in the treatment of mild, moderate, or uncomplicated acute rhinosinusitis was not useful by the most of the controlled studies. And it's not recommended by almost all clinical guidelines. There is a big investigation from the EU, and it's telling our use of antibiotics have a result, and we are calling that result antimicrobial resistance. That is the picture from the World Health Organization. It's telling to us that soon, not far away, in 30 years, we will have a problem. We will be dead from simple scratching because of antibiotic resistance, because of not clever using antibiotics today. Well, we know when to prescribe antibiotics, now we have to choose which antibiotics. All over the world, the antibiotic of the first choice is amoxicillin. If there is no effect in 7 days, you can change it to amoxicillin clavulanate. Amoxicillin combined with clavulanate Acute. If the patient has allergy to penicillin, we can use cephalosporins or macrolides. In the United States, there is a prescription from the Infectious Disease Society. They give advice that the first drug can be used already, amoxicillin clavulanate. What about duration of the treatment? In adults, it should be nearly 7 days. It shouldn't be longer than 10 or 14 days. You know that shorter treatment without severe disease complication factors, they are really helpful. But if you prescribe longer, it can lead to antibiotic resistance and to much more bigger loss of costs. In kids, duration of treatment should be 10 to 14 days. Well, next one is topical steroids, or combination of topical steroids and antibiotics. Topical steroids, they should be used in case of post-viral rhinosinusitis. In the case of combination antibiotics, they will be used only in the case of acute bacterial rhinosinusitis. There was 3 trials. The examination was done for patients with acute viral rhinosinusitis or common cold. And in 2 placebo-controlled trials, there was no benefit of nasal corticosteroids for treatment of acute viral or common cold. They are, intranasal corticosteroids are recommended for treatment of acute rhinosinusitis, both in moderate and severe types of disease. One of I will show you one example. There was a double-blind placebo-controlled study. There was nearly 1,000 patients with the symptoms of acute rhinosinusitis. The patients were divided into groups. One group received mometasone furoate one a day, another group mometasone furoate twice a day. And the group number 2 received amoxicillin, the last one placebo. Mometasone furoate, it's corticosteroid. Well, here you have a result. And it shows that the best result was in the group where mometasone furoate was used twice a day, is giving the best result. Also, from the investigation, we know that using corticosteroids is showing to us fast result. From the first 2 days, we already receive nice result. The symptoms are going down. And very interesting, they proceed to going down, they will proceed to be decreased until the end of the treatment. About recurrence, in the case of a group when there was mometasone furoate used twice a day, recurrence happened the most rarely. Complication. Very often patients are afraid of complication. They tell, oh, it's steroids. Oh, doctor, I'm afraid. I don't want to be fat. Don't be afraid. They are quite safe because they didn't penetrate to the vessels. They didn't go to the HEPA. That's why there will be no general complication. The most difficult complication is for me, it's nose bleeding. It happens in 6 cases. When we use mometasone twice a day, but when we look at placebo, it also happened. It's nearly close. That's why don't be afraid of topical corticosteroids. Well, usage of mometasone furoate, and to compare with antibiotic treatment, there was again double-blind randomized placebo-controlled study. There was nearly 500 patients. In one group, there was using of mometasone furoate combined with antibiotics. In another group, there was antibiotic with placebo. And again, the best result was in the group with acute bacterial rhinosinusitis, which will take a treatment antibiotic with topical corticosteroids. It's clearly shown general result, and also we can see the result by every symptom. And it was much more better in the group where the treatment was combined antibiotic and topical corticosteroids. The data was also supported by other investigation. Prophylactic treatment of recurrent acute rhinosinusitis. Well, there was investigation. There was nearly 200 patients. They one group take topical corticosteroid, fluticasone propionate, twice a day. 4 times a day. Another was placebo. And in the group with topical corticosteroids was nice result. It was much better than another group. Recurrence appeared nearly 19%, another group nearly 34%. It's a good result, it's showing it's helpful, but statistically, that investigation was not significant. Well, oral steroids, due to protocol from EPOS, they can be used like addition to antibiotics in the case of acute bacterial rhinosinusitis. And EPOS is giving very nice, the biggest level recommendation and great recommendation. The results of recent cohort analysis suggest that oral corticosteroids is an adjunctive therapy for oral antibiotics are effective for short-term relief of symptoms like headache, facial pain, nasal decongestion, and so on. But systemic corticosteroids without or with antibiotics do not have a positive effect on duration. There was a nice investigation. It was also placebo-controlled, nearly 400 patients. One group, they received just oxycodone. Another group received methylprednisolone. Well, there was no difference in therapeutic outcome. In both cases, the problem was finished in 14 days, but at day 4, there was a significant reduction in headache and facial pain in the group which take steroids. Another investigation was a placebo-controlled study, 289 patients. One group take cefpodoxime, another group take also prednisolone. And there was the same result. There was no difference in the complete finish of the problem, but group which take prednisolone, there was a fast relieving of the symptoms like headache, facial pressure. Well, the usage of oral corticosteroids is recommended for adults with acute bacterial rhinosinusitis, which is suffering from severe headache. Also, for sure, if there is no contraindication for their usage. Well, antihistamines, analgesics, and decongestants. Yes, they can be prescribed in the case of acute viral rhinosinusitis. They are widely prescribed, very often are prescribed, but especially in the case of viral rhinosinusitis. They are fastly relieve edema, and they are quite helpful. Again, only in the case acute viral rhinosinusitis or common cold. Topical decongestant. It's the most widely used drugs by our patients. They're using that due to any problem with the nose. It's easy sold without any prescription. And it's the most common drug which is used for treatment of acute rhinosinusitis. What is the purpose? Very often patients are using that to decrease the congestion with hope that it will help, that will improve better sinus ventilation and drainage. They have really short duration, reduction of symptoms due to the congestion, but they are not completely effective on etiology and pathogenesis of the problem. They didn't have no influence on infection and inflammation. They have small positive effect to the nasal decongestion for patients with common cold. What does it mean? For patients with first stage acute viral rhinosinusitis. There was made a few trials that explain that nasal decongestions, topical vasoconstrictors, they have nice effect on the nasal cavity. They reduce congestion, they improve breathing, but there was no complete effect on the paranasal sinuses. There was no changes. That is a very typical picture with patients with nasal decongestions. Patients are drinking that drug through the nose like that. And they don't understand it's quite dangerous drug. There is a big amount of different complications like burning, stinging in the nose. It also produces increased mucus production, high blood pressure, headache. This contributes also cardiovascular risk. One of the dangerous complications of using nasal decongestion is necrotic changes of ciliated epithelium. And if you got necrosis, like it is mentioned in that picture, the problem will be transferred to chronic rhinosinusitis. Another complication that vasoconstrictors they will slower the moving of cilia. They will stop in 2 or 3 hours, while in control group, the movement of cilia will be for nearly 5-6 hours. That's why it's really dangerous and not clever to use topical vasoconstrictor so widely like it is used. Well, another one, saline irrigation. You also have a big level of recommendation, big greater recommendation. It have different names like nasal irrigation, nasal douche, wash, lavage. It's a procedure that rinses the nasal cavity with water or some other antiseptics. Most often it's isotonic or hypertonic saline solution. It's quite habitual and EPOS is telling that we have to prescribe it in the case of acute rhinosinusitis. It's also effective in children, and it can prevent from recurrent infection. Steam inhalation. Well, the theoretical basis why we have to prescribe it, that steam may help congested mucus drain better, and heat may destroy the cold viruses as it is done in vitro. But it's not recommended in the routine treatment of common cold symptoms because there is no enough evidence, and that steam inhalation didn't show any benefits from its usage. Ipratropium bromide, it have big level and greater recommendation, especially in the case of viral rhinosinusitis. We have another name like Atrovent. It's a blocker of M-cholinergic receptors. It's used for treatment of chronic obstructive pulmonary disease and asthma. It opens medium and large bronchs. It was performed in Cochrane review. And it is shown it's effective in the case in ameliorating rhinorrhea, but there was no effect completely to the nasal congestion. There was more side effects. That's why it shouldn't be used. Vaccination. Well, development of a vaccine for the common cold is very difficult because there's a big amount of different viruses. They are subdivided. There are a big amount of different antigens, and we are not sure which antigen will be that year. There is no direct effect on the acute rhinosinusitis, but however, routine child vaccination has effect, vacancy, on the acute virus media and acute bacterial rhinosinusitis. It was found that immunization lead to increase of host-resistant capabilities, decrease of acute respiratory disease incidence, and changes in structural complication due to infection. Well, non-steroidal anti-inflammatory drugs, aspirin, paracetamol. There was multi-center randomized, double-blind, double-dummy, placebo-controlled study, nearly 400 patients. In one group there was single dose of aspirin, another group there was acetaminophen, and another was placebo. It was helpful, but it was helpful only due to headache, and there was not another help. The Cochrane review was performed to determine is it effective or not, and as a result, non-steroidal anti-inflammatory drug, they did not significantly reduce the total symptoms, and they are recommended only in the case of the common cold to relieve this discomfort or pain. In the other cases, they are not quite recommended. Well, vitamin C, it's a lot of people believe that it's helpful, and to use extra vitamin C to protect you from infection. It will increase your protective system, it will improve your immunity, but there was no clear evidence that it's helpful. There was very amount of investigation, doesn't show any help for treatment of acute rhinosinusitis. But there was one exception. It was helpful only for persons who working highly in physical work and in not comfortable temperature. For example, sailors. Only in the case of sailors, it was helpful. Well, mucolytics. There's no big amount of investigation, but we know that nasal cavity, paranasal sinus cavity is covered by ciliated epithelium, by cilias, the same cilias like we have in bronchs and trachea. And when we have inflammation, the mucus, which is physiological mucus, which is covering the ciliated epithelium, is going to be more thicker, and for better solving, for better and easier evacuation of that discharge, we will prescribe mucolytics. They are recommended as a good treatment for acute rhinosinusitis, but we still need further investigation. Herbal medicine, yes, it can be prescribed, it's widely used. but it can be prescribed and widely used in the case of viral and post-viral rhinosinusitis, not in the case of acute bacterial rhinosinusitis. There was a few drugs, Benio 116, Semiola, and Andrographis paniculata. They show significant, they show nice result in the case of common cold. Chromoglygats, it's a drug which can be used for treatment of allergic rhinitis. There was some improvement of the symptoms in nearly 50% of the case, but there was no difference between the patients which take chromoglygats and placebo. They take simple saline. That's why it's not, it didn't have a nice level and greater recommendation by EPOS. Echinacea, it's also popular between our patients. It's one drug which is treating everything. It can treat you from cold to cancer. Assuming it's a big question. And there was also investigation, and there was no received clear result that echinacea can help us in the case of acute rhinosinusitis. Homeopathic products, they're also used, are often used. Our patients like it because they think that they are very safe. There is no evidence, there is no side effects, but there is no clear evidence that they are completely helping us. That's why they are not recommended. Exercises, there was a big investigation which shows that regular, moderate, intensive exercises may have a positive effect for prevention from common cold. Well, again, acute rhinosinusitis can be treated by the patients as a self-limited problem by itself. Also can be treated by a family doctor and otolaryngologist. From EPOS 2012, we have a special protocol. It's very helpful, especially for the general doctors. It's showing how the patient should be treated, depending from the type of rhinosinusitis. And if there is no effect, the patient should be sent to the AT doctor. Also, AT doctor have his personal protocol, and he tells which steps you have to do one by one. Complication, acute rhinosinusitis complications. Well, incidence of acute rhinosinusitis complication is approximately 3 per million of population per year, and it's not reduced by antibiotic prescription. In patients which are hospitalized for sinusitis, the rate of complications is from 3 to 20%. Classification of complication. They are orbital, intracranial, and bony. The most often appear orbital complication. Very often they are mixed. They be orbital, intracranial, and bony together. The most common complication of the rhinosinusitis are orbital complications, and they are associated in order of decreasing frequency with ethmoid, maxillary, frontal, and rarely sphenoid sinus. The spread of infection directly via thin bone, which separates the cavity of the nose from the orbit, or by veins, it's a nice condition for development of complication. Very important to note that orbital complication in kids may occur without pain. You can see on that picture, here you got the orbit. Over here it borders with maxillary sinus, quite thick bone. Over here it borders from the ethmoid sinus, posteriorly from sphenoids, and that bone is very thin, the thinnest bone of the orbit. Sometimes it's thin like a paper. Over here it borders from the frontal bone. Look at that CT scanning. You can see lamina papyrosa. It's a thin bone which separates ethmoids from the orbit. Sometimes we even couldn't see that on the CT scanning. According to the Chandler's classification, orbital complication may appear in the following steps. The first one is preceptal cellulitis. Next one is orbital cellulitis. supraorbital and orbital abscesses, and the last one is sinus cavernosus thrombosis. Orbital complication, when you look at that picture, you will see that those easiest, fast steps, like preorbital and orbital cellulitis, they will take only 40%. Complicated, more difficult complication, like orbital and supraorbital abscess, will take nearly 60%. Preseptal cellulitis. Inflammation of the eyelid and conjunctiva involve the tissues anterior to the orbital septum. And what is it? Orbital septum. Orbital septum is membranous sheet that acts as anterior boundary of the orbit. It extends from the orbital rims, over here, to the eyelids. It forms the fibrous portion of the eyelid. What are the signs? First of all, it's orbital pain, not too severe, eyelid edema and erythema, conjunctival injection, slightly blurred vision, teary eyes, sometimes fever, and typically there is no association with proptosis and limitation of eye movement. Normally it's easily treated. They will prescribe antibiotics, and it's very also, remember, it may spread beyond the orbital septum, it can progress. Mostly it's enough clinical investigation. You don't need some other test, for example, CT scanning. You can see on that picture, we got edema of the superior eyelid, there is some redness, teary eyes. The same from that side, just more prominent. We are not doing routinely CT scan, but in some cases we are doing that. Look here, and you can see both eyelids, they got edema, both eyelids. In that picture, much more better we can see. Well, right eye is okay, there is nothing. On the left side, we got edema of the eyelid. Also, you can see maxillary sinusitis. Orbital cellulitis. When already inflammatory changes involve the orbit, develops proptosis, and also develops some limitation of ocular motion. Typical signs, except those which were mentioned in preorbital cellulitis, they will include plus conjunctival edema, we call it hemosis, protruding eyeball, call it proptosis, ocular pain or tenderness, restricted and painful movement of the extraocular muscles. Now it requires more aggressive treatment. You got the picture. Severe edema of the eyelids, superior and inferior. You can see hemosis. On the CT scanner, you can see we got ethmoids are affected, and over here you can see the inflammation inside of the orbit. Another CT scanning, also ethmoids are affected, and you can see over here affection of the ethmoids and edema of the eyelid. Supraorbital and orbital abscess. It's much more difficult complication. We start from the supraorbital abscess. It forms between the periorbital and the sinuses and is extraconal. That means it's localized outside from the muscles. You can see the muscles, and it's outside from the muscles. Well, what are clinical features? Edema, erythema, hemosis, proptosis of the eyelid, limitation of ocular mobility, high fever, raises of leukocytes, also as consequences, extraocular muscles paralysis, globe becomes fixed, and visual activity diminished. Orbital abscess is intraconal, that means it's placed between the muscles. Well, mostly it happened in patients with delayed diagnosis or immunosuppressing patients. You got the clinical picture of the abscess. From that picture, clinical visual, severe edema of the eyelid. You can see hemosis, discharge of the pus. Look at the picture. You got CT scanning, nice abscess inside of the orbit. Another abscess, look, frontal sinus is affected, maxillary sinus is affected. Here you got abscess from frontal side. You got 3 dimension. Well, another abscess. Look here, you got maxillary sinus, ethmoids, and abscess inside of the orbit. In the case of orbital complication, we can do MRI examination. In that case, you will see that one sinus is affected, another sinus is affected. We didn't see the bony structures. It's completely dark. It's not visualized on the MRI, but we can see there is pathological changes already inside of the orbit. Treatment is only surgical. What are indications for surgical treatment? Evidence of suprarostal or intracranial abscess on CT or MRI, reduced visual activity, reduced color vision, affected afferent pupillary reflex or inability to access vision, progression or non-improving orbital signs after 48 hours treatment with antibiotics, progression or not improved general condition after 48 hours of treatment with antibiotics. Well, there are very restricted indication. Also, there are some contraindication, but they are possible only in the kids of 2 years, from 2 to 4 years old. We can try to treat the patient without surgery. If you got clear clinical improvement within 24-48 hours, no decrease of visual activity, small medial located suprarostal abscess, and no significant systemic involvement. In that case, in kids, we can try to treat without surgery. Well, next one, endocrineal complication. They can be different. They can be epidural or subdural abscess. They can be a brain abscess, meningitis, cerebritis, superior sagittal or sinus cavernosus thrombosis. The clinical presentation of endocrine complications, sometimes they can be non-specific. They can be just symptoms like high fever, headache, that's all. Sometimes it can be completely silent. Remember that. Very often it's very silent. But most often they have direct signs like nausea, vomiting, neck stiffness, altered mental changes, focal neurological changes, behavioral changes, severe headache. You got CT scanning. On that CT, you can see that you got damage in the frontal, and over here you got abscess. The same over here, you got abscess of the frontal lobe. Well, sinus cavernosus thrombosis, due to well-vascularized region of the orbit, to the well-developed venous vessels, infection easily can be spread from the orbit to the sinus cavernosus. And it's a very dangerous complication because mortality rate is nearly 30% and morbidity rate is nearly 60%. It's a very difficult complication, but it's a rare complication. From all intracranial complications, take nearly 10%. Well, what are the symptoms? It's bilateral lip drop, exophthalmos, ophthalmic nerve neuralgia, retroauricular headache, and deep pain behind the orbit, complete ophthalmoplegia, papilla edema. And remember, it always starts from one side. One eye will be affected, but sooner or later, sometimes opposite eye also will be affected. Except local changes, there will be systemic changes like meningeal irritation, there will be changes in the blood, and also there will be changes in the lumbar liquid. What about diagnosis? We have to do both MRI and CT scanning. In MRI, we will see that during contrasting the vessels, the sinus cavernosus is absent. He is present, just the contrast is not inside. What about treatment? The treatment should be very aggressive because the problem is really dangerous. In the treatment, we use anticoagulants. For sure, if there is no contraindication, big dosage of the anticoagulants, we will use intravenous antibiotics. Very often there will be several antibiotics. We will use big dosage of corticosteroids, and very important, there should be done surgery. There should be all sinuses should be opened. Next one, bone complication. Well, all the sinuses they are surrounded by bone, and infection site can be spread to the bone tissue and lead to the necrosis. Well, I show you a few CT scans. You can see the frontal sinus is affected, and over here I got damaging of the frontal part of the frontal sinus. The same over here. You can see the MRI. There is no bone. We couldn't see the bone over here, but you can see that infection is spread from inside to the brain box. Again, CT scanning. We have direct opening from outside to the brain box through the sinus. Clinical picture, you can see, looks like that, like somebody put some ball behind the skin. Or can be like that, necrotic changes on the skin, necrotic changes on the eyeball, necrotic changes on the maxilla. Look here, there is no bone structure completely. There is severe necrosis. But like here, there is no necrotic change outside, but there is necrotic change inside. There is no bone structures inside of the nasal cavity. Nasal septum, the bone which separates the maxilla from the nasal cavity is solved. Also, there are some unusual complications. They are different. They can be like abscess of the nasolacrimal duct, abscess of orbital hematoma. They can be stroke, and so on. It happens, but not so often. Remember, acute rhinosinusitis, it's self-limited problem. Very often it will pass by itself. Often the patient will treat it without any doctors. It will do it by itself. He make the self-prescription, and also can be treated by family and ENT doctor. Thank you very much.